Good afternoon, everyone, and welcome to the HRSA Spins Initiative, Improving HIV Outcomes through the Coordination of Supportive Employment and Housing Services, what we also call the HIV Housing and Employment Project. We would like to thank you for joining us this afternoon as we come today to our final project for this initiative and wrapping up this 3-year initiative here today and talk about the outcomes and lessons learned from this very important initiative. Before we get started, we would like to welcome Dr. Laura Cheever, our Associate Administrator for the HIV/AIDS Bureau, as she will come this afternoon and give us greetings. Dr. Cheever?
Great, thanks so much, and thanks for having me here today. I'm really excited to be here. I know all of you know that in the Ryan White program, our goal really is to provide high quality HIV care and treatment for all. And this initiative specifically supported the design, implementation, and evaluation of innovative interventions, coordinating HIV care and treatment with housing and employment services to improve health outcomes for low-income, uninsured, and underserved people with HIV in racial and ethnic minority communities. We underwent this initiative really based on input from the community about what we were missing. We had worked on some housing work before, and people said if you don't address employment, then you're not really going to ever help people get out of poverty. We had a challenge because the Ryan White program isn't really an employment program, and it's not ever going to be an employment program given the current legislation. But how could we really better link to resources and leverage the work we do in housing to also work on employment? The other thing I'll say is we've made tremendous progress in the Ryan White program in the last few years of really reducing health disparities. So the gaps we had between the national rates and rates of specific subpopulations, we've actually closed those disparity gaps. We have not done that for unstably housed people. Unstably housed people have improved their viral suppression rate as we've improved our rates nationally, but the gap between people that are unstably housed and stably housed has remained consistent. So we know that in order to really reduce disparities, we need to get people housed. And certainly employment is an important part of long-term housing for most people. The overall goal of coordinating service interventions to increase the impact of social determinants of health, including unmet housing and employment needs that affect long-term HIV health outcomes for people with HIV impacted by these instabilities, has been a major focus of this initiative. This initiative was supported through Department of Health and Human Services, Minority HIV/AIDS Fund, the MAIF Fund, which comes from the department to us, as well as through the Special Projects of National Significance. And I've got to say that when we went around the country and when we were able to still travel and really meet with communities, issues around housing and employment are just fundamental as we try to end the epidemic in this country. So the work you've done in the past few years has been tremendous. I'm really excited to start seeing these analyses so we can take what we learned here and really expand it tremendously. I'm going to turn it over to Antigone Dempsey, who's the head of the Division of Policy and Data, which is where the SPINS program now resides. And she's really been focusing on this concept of dissemination. So I'm really excited to have her here today with us as well. Antigone?
Thanks, Laura. Well, first of all, I just want to welcome you all and say hello. I'm new to many of you because of the reorganization, and we've been working very closely with our colleagues in SPINS, and I'm very excited to be able to be a part of today and tomorrow's meetings. I'll be in and out a little bit, but I was going to talk a little bit about what Laura touched on already around actually, the findings for this project is perfect because we really are implementing our ending the HIV epidemic plans and work in the Bureau, and housing has always been a challenge, but more recently people have really been talking about employment, and that has really raised. So it's perfect timing for all of us to be able to hear what you've all been learning and the great work that you've all been doing. So I did want to note that the coordination center for this this overall project has two major funding. We have the Evaluation and Technical Assistance Provider, the ETAP, which is Boston University. And then there are 12 demonstration sites, as I think that you're all aware, across the country. Laura already touched a little bit on our Ryan White Services data and the outcomes there. And I just need to emphasize consistently, if somebody is not stably housed, the viral suppression rates are greatly impacted more than across any other variable in our data. We actually recently published a paper in PLOS Medicine about this, looking at our data and talking about this. So I want to make sure you guys were aware of that too. I want to recognize the collaboration over the past 3 years with HUD and HACWA and the Department of Labor. We really value that collaboration. As Dr. Cheever already mentioned, you know, Ryan White has limited funding, and we have to be able to leverage what else is out there. And through that collaboration is one of the major ways that we do that. This initiative has really helped align our HHS and HIV/AIDS Bureau priorities of increasing collaboration. As we talked about, collaboration is so important for this. Promoting innovations, increasing efficiencies, and strengthening the well-being of people with HIV across the lifespan. And I do think that that's really important here too, because this is about not just reaching viral suppression, but about quality of life. And that's just so important if we're gonna keep going on in the way that we need to go on to end the epidemic. Even in 10 years, many of us with HIV will still be living and alive and need to have a quality of life to want to keep going. And employment and housing are two critical pieces to that. So we talked already a little bit about the data, so I won't go into that, but I really look forward to learning from you all. And I just really also want to thank you all for the work that you've been doing over the past 3 years. This is just such important work and so helpful for the work that we're doing in the Ryan White HIV/AIDS program. I really look forward to hearing about the innovative models and partnerships that you've all been engaged in. So thank you. I'll hand it back over to Corliss.
Thank you, Antigone and Dr. Cheevers, for your warm welcomes and your greetings. Next slide, please. And for those who may not know me, I'm Corliss Heath, a health scientist in the SPINS branch, and I also had the pleasure of serving as the project officer for this wonderful project. And so as we get started, just to talk about a little of the social determinants of HIV health outcomes for housing and employment. As we also already discussed, among the Ryan White clients who are virally suppressed, 72.4% are unstably housed versus 88.4% who are stably housed. And when we look at that, 12% of the unstably housed people with HIV only had access to some time of employment. Here we find that employment is associated with movement along the HIV continuum, which includes HIV testing, linkage to care, and adherence to medication. And so within the HRSA SPINS, building a medical home for HIV homeless populations, we found, which was a previous SPINS initiative, we found that navigation interventions were associated with improvements in HIV health outcomes. And so we took some of that data to help in terms of looking at evaluations for this particular project. Next slide, please. In moving towards the goals for this particular initiative, one of the things, or a couple of the things that we were looking to do was to design, implement, and evaluate innovative models of coordinated care service delivery across 3 sectors. And those were HIV care services, housing, and employment. Particularly, we wanted to improve engagement and retention in HIV care and supportive services for people with HIV who were impacted with housing, and that's unstably housing, and individuals who who were had employment instability, and those individuals who were either unemployed or underemployed in racial and ethnic minority communities. Next slide. As Antigone said, we had 12 demonstration sites and 1 ETAP across the United States. Our ETAP was at Boston University, and as you can see from our map, these were where our 12 demonstration sites were located, from the East Coast to the West Coast, as well as in the South and in the Midwest. Among those 12 demonstration sites, we had 4 city and county health departments, 4 HRSA health centers, and 4 AIDS service organizations or HIV comprehensive care agencies. Next slide, please. Also, when we look at our 12 demonstration sites and intervention projects, overall, the 12 sites were what we call care coordination and navigation centers. But also within that, 3 of the sites provided system-wide case management training. 3 of the sites provided streamlined referrals within their system. 2 sites expanded their IT capacity and data health integration within their systems. 8 of the sites had Ryan White, HUD, Hopper partnerships. And then we had 3 sites that had partnerships with the Department of Labor agencies. And as we look at these, all of these are mutually exclusive. Next slide, please. Among the participants or the clients within our 12 demonstration sites and within our project, these are the eligibility criteria in order to participate in the HIV Housing and Employment Initiative. Number 1, individuals had to be 18 years or older. They had to be HIV positive, and then also include one of the following criteria. They had to be newly diagnosed within 12 months and not engaged in HIV primary care or at risk of falling out of care, and then or not virally suppressed. They also had to be homeless or unstably housed or unemployed or underemployed. Next slide, please. And now I will turn it over to Serena Rajabian, the co-PI for this initiative, and she will talk to us more about the preliminary findings from the HIV Housing and Employment Project. Serena?
Thanks, Corliss. Hope you all can hear me well. And thank you all for coming out today, to Dr. Cheever and Antigone for finding time to hear some of our preliminary findings. And to all of you out there, we're excited to share these findings with you. My name is Serena Rajabian. As Corliss said, I'm the co-principal investigator for the Evaluation Technical Assistance Center housed at Boston University. And before I get into this, I just want to say thanks to all my team at the Evaluation Technical Assistance Center for helping produce these findings. So next slide, please. So what I'm going to talk to you about today, our objectives over the next half an hour is we're going to describe the clients that were reached and served by the SPINS intervention. We're going to share some of the preliminary implementation and client outcomes related to HIV health, housing stability, and employment. And we're going to talk about different profiles of clients that fall into those groups. And we're going to identify lessons learned for replication from a site and client perspective. In this first session today, you're going to hear from 2 of our partner sites and their clients about their experience. And then later this afternoon, if you can come back and join us, we're going to go deep, take a deeper dive with some of our sites about the results and lessons learned from the employment side of those interventions. So we hope you can stay for the whole day today. Next slide, please. So before I get into the findings, just a little bit about our framework and methods for the evaluation. We used a framework called Mittler's Consumer Engagement Framework. And this framework really looks at the individual, community, and structural factors such as housing and employment, the environmental factors that motivate individuals to get engaged in services. And not just employment and housing services, but also HIV healthcare. So we set up the intervention that way. Our data collection is from May 2018 through August 2020. We looked at client outcomes where we did a longitudinal observational survey. We had interview data collected as well as medical chart review for the HIV health outcomes. And we also collected information on implementation, activities, and process that I'll share with you today. That mainly comes from the encounter forms that the SPINS intervention staff collected, as well as a qualitative study that we did at 8 sites with client participants. Next slide. So in terms of the analysis that I'm going to share with you today, we'll be sharing only aggregate descriptive data. and it's limited to a post 6-month follow-up. As I mentioned, our data collection just closed at the end of August. So we have clean data, and the sites have worked really hard to give us clean data on both interview and chart. So we're taking it up to that time frame, and then hopefully in another few months we can come back and talk about longer term outcomes. And we'll also be using a latent class analysis to look at client profiles by housing, employment, and health outcomes to get an understanding of where our interventions work for different client profiles. The other limitation is that we do have some missing data, you'll notice as I present, mainly attributed to some COVID-19 restrictions that happened last spring, which resulted in delays or inability to conduct medical chart reviews. And also we had some clients that were lost to follow-up because they didn't have phone access to do some of the follow-up interviews. Next slide. So let me give you a little description of who our housing and employment participants were. The intervention sites, in a course of just about under 3 years, I would say, because of the COVID epidemic, served 1,261 clients. And among that group, a little over 1,000 were enrolled in the multi-site evaluation. And these clients, the majority were unstably or literally homeless at the time of enrollment. The majority were cis male, and we had about 5% who identified as transgender or other identity. In terms of age, the majority were working age between 31 or 54, but we had a small percentage that were in the older population, 55 or older, which I think has long-term, we want to look at a little bit more in terms of how, as the population ages, what might be some of the employment concerns there as well. Majority were from racial ethnic minority communities. We had 18% that were actually foreign born. And in terms of education, we had a fair distribution across the various education sectors. So we had about 38% had some college degree, but about half our participants either had high school or less than high school. Next slide. And other risk factors, the SPINS intervention also reached a very vulnerable population in terms of social risk factors. 2/3 of our participants had an incarceration history. A majority had suffered from some sort of high risk of mental health, including depression or anxiety. 40% had a trauma history, and 1 in 5, about almost half had a high risk for alcohol use, 1 in 5 on cocaine, and about 11% had high risk dependency for opioids. And approximately 2/3 were characterized as food insecure, very high food insecure risk. So a very high vulnerable population that our grantees were able to reach out and engage in the SPINS intervention. In terms of our HIV health outcomes, and this is at 6 months, when we look at our chart data, nearly 3/4, 77% were able to be linked to HIV primary care within 3 months post-enrollment. Almost half were engaged in care, and we define this as being about 2 appointments in 6 months, at least 90 days apart. And then in terms of viral suppression, at 6 months, again, about 3/4 of our participants were virally suppressed. Next slide. And then when we looked at viral suppression and change from enrollment to 6 months, about 77% had either gained or maintained that suppression, which I think is an important point to see that even in terms of staying connected with the system, the intervention staff were able not only to work people towards housing and employment, but ensure that they either achieved viral suppression or maintained it if they were virally suppressed at baseline. And about 1/4 did not reach viral suppression. Thanks, Marina, sorry about that. Next slide. In terms of changing the housing status, and again, this is just the 6-month period, about 23% stayed homeless. 1 in 4 obtained or stayed in temporary housing situation. And in terms of permanent or stable housing, 41% achieved that by 6 months. And we also had about 11% who became more unstably housed. And that was perhaps they were in a stable situation at the beginning, were in immediate risk for homelessness, but the interventions maybe got them into a temporary housing. So we saw some change in that stability, but overall, you can see that at 40% in this short time frame were able to get to a stable permanent housing situation. Next slide. Of employment, one of the indicators that we looked at here is a reduction in employment barriers. And we asked participants what were some of the barriers, both at baseline and 6-month, barriers to returning to work. And so these light bars, light red bars represent the baseline barrier, and the dark represent the change at 6 months, what we saw happen at 6 months. So in the beginning, we saw most of the top barriers to care were related to health concerns about returning to work. Either they weren't feeling healthy enough, or they were concerned that they would not be able to take on the stress of work. They were fearing that they might have an inability to take time off from work. And a third of the participants also expressed fear of not having the skills at baseline to go to work. Another third felt that they would not be able to meet those demands, or that the stress would affect their job. And interestingly enough, we saw that 25% actually had a fear of disclosure and experiencing stigma if they returned to work. So relatively high, fair proportion of barriers at baseline. And you'll see at the 6-month, there was a reduction in those barriers over time. And we'll be monitoring this up to the 12 months too, to see how this might have changed. Next slide. Another point I want to share with you about changes in employment status. So when we looked at our sample, this is a cohort that had both baseline and 6-month data. There were about 38% who were not seeking employment at baseline, or at the 6-month point, maybe they had been in the job market and then lost motivation. But by 6 months, we still had among that cohort about 40% who just were not ready yet to seek employment, but about 23% as a result of being in the intervention actually became motivated. They started to look for employment. And then overall, in 6 months, we saw that 2/3 were actually in seeking employment overall. So we did see in our sample that there was a cohort at 6 months who weren't seeking employment, and then the majority though were seeking employment. And among that cohort, about 1 in 5 were able to gain or stayed had a formal job, either part or full time. Another third we saw were what we call motivated workers, meaning they had been unemployed at baseline and seeking for work and wanted work. And by 6 months, they had maybe gotten a temporary position or working part-time, and they still might be considered underemployed, but they had achieved some sort of position. And then about half were still in the market. They were still what we call job seekers, looking and working to find a position or building those skills to get towards some sort of formal job. Next slide. Okay, and at this point, I want to turn it over to Tom, and he's going to describe some of the results we found in the different groups we saw in terms of who got housed and employed. Tom?
Yep. Hi, everybody. Can you hear me okay? Okay, great. I'm Tom Byrne, co-principal investigator, part of the ETAP team here at Boston University. So Serena's taken us through a number of the sort of descriptive characteristics of participants. Another way that we wanted to try and understand participants and their outcomes is to use a statistical method known as latent class analysis that allows us to identify distinct subgroups of participants who the members of each group who are similar to one another but different from members of the other subgroups. So what we did is to try and construct these subgroups or identify these subgroups on the basis of their housing situation, employment status, and whether they were virally suppressed at 6 months. And doing this allows us to identify sort of heterogeneity within our participants after having been enrolled in the interventions for 6 months. And it allows us to sort of see whether there are different subgroups with respect to their housing, employment, and whether they're virally suppressed. Again, keeping in mind here that eligibility criteria required folks to be homeless or unstably housed, unemployed, and not necessarily to be virally suppressed, but to meet one of the criteria that were noted earlier with respect to their HIV status. So what you see here is kind of the summary of what we found, and we identified 3 distinct subgroups of participants at 6 months. So group 1 is a group that comprised about 35%, a little bit more than a third of all participants. And this was a group that was characterized mainly by the fact that they had housing and employment challenges. So about 2/3 at 6 months were literally homeless or unstably housed. On the other hand, 100% were virally suppressed, and only slightly under half, about 44%, were employed. So this is a group that was characterized mainly by their housing and employment challenges, but 100% were virally suppressed. So the second group that we identified comprised about 20% of all participants, and this was a group that had mainly housing challenges. So about 2/3 were literally homeless. However, 100% were employed and nearly 80% were virally suppressed. So when we think about our sort of 3 key outcomes here, this is a group that was doing well on 2 of the 3, but was still struggling with housing stability. Now turning to the third group, this is the largest group that we identified. It comprised 46%, so almost half of all participants. And this was a group that had mainly employment challenges. So nearly 3 in 4 were stably housed at 6 months. 3/4, again, 3 in 4 were virally suppressed, but none of these folks were employed. So this is a group that was doing fairly well with respect to housing and viral suppression, but we're still having employment challenges. The one caveat here is that folks, just the way that this employment variable was constructed, that the folks who were unemployed by our definition would include some folks who might not be looking for work for one reason or another. But this kind of gives you a sense of there's real clear heterogeneity among our participants. So with respect to sort of these 3 key outcomes and where they were at 6 months. So sort of 3 distinct groups that we identified. So we can kind of move to and I would be curious to hear later on during the Q&A whether those 3 groups resonate with folks, whether they can think about or whether mention of those 3 groups calls to mind specific clients who participated in the intervention at any of your sites. All right, so we'll go to the next slide here. So this is just a summary of the encounters. So the encounters kind of just to sort of summarize the delivery of the intervention and the amount of intervention that folks received. So this is all at 6 months. So there was a total of nearly 12,000 encounter forms, which included about 9,500 direct contacts with clients and about 2,000 contacts, which represented time doing outreach and locating clients. So a lot of activity going on. Of those nearly 9,500 direct client contacts, about half were housing related, about 30% were employment activities, and 15% were medical care support. So that sounds like a lot, right? 12,000 encounters. What that averages out to is about 9 encounters per participant, although there's a wide range there, anywhere from 1 to 80 encounters. And those 9 encounters break down to, on average, about 5 housing-related encounters per participant and 4 employment-related encounters, although again here a really wide range. And the average duration was about 40 minutes per participant per encounter. So on average, folks were spending about 40 minutes per encounter with clients. And again, huge range there. And the average caseload size per interventionist was about 32 clients. And now I'll turn it back over to Serena, who's going to take us through some of the findings from the qualitative component of the evaluation, and we'll hear some client perspectives.
Thanks, Tom. Yeah, so to complement the quantitative data we collected, we also wanted to capture some of the client voice in terms of actually how the SPINS intervention address some of the barriers to obtaining the medical and social services. If you can keep going, Marina. Also looked at, as I mentioned before, we were really concerned, our theoretical model looked at how these interventions would motivate clients and engage them in medical and social services. Third, we wanted to see how housing or employment might impact clients' healthcare engagement and health outcomes and quality of life. And then just their experience with the intervention. So this was the goal of the qualitative. And some of the themes that we found that came out from how the SPINS interventions support. First, they provided that direct provision of housing related resources. So with the SPINS dollars, they were able, for example, to obtain emergency shelter and housing, which was very critical, particularly for people who were either literally homeless or maybe if they had been stably housed and needed to go into a temporary situation. Also, the interventions help them with rents, any sort of back rent or utilities. The other major theme that we saw was in terms of just logistical support around housing. Having someone who could send apartment listings that accept TBRAs, having support to get transportation to go look at a housing, in different types of, it's a very intensive service for housing support, so that logistical support and getting there with paperwork was really critical. A third major way that they got support was keeping up to date with providers and case managers, having someone who could give them the status of where their housing application was and helping them network with various housing providers. Another important service that was offered is around coaching. The SPINS interventions and intervention staff were really helpful in modeling how to walk through an apartment and what to note and talk with the landlord about. Also helping with budgeting was really critical in terms of making sure that their income they did have coming in would last and prioritize payment for basic services, rent and food. A third area was around motivation and counseling. Just having that person there who could help the client think about new ways and new ideas for either for finding a housing situation, pushing them, and getting independence as well. And then finally, and not surprisingly, was around just help with basic needs. especially when faced with, if they were homeless or faced with an unstable housing situation, getting hygiene products, furniture to, if they did get housed, bus and subway cards to get to see housing options were all really critical. Next slide. And then in terms of, oh, sorry, and this, we just wanted to share with you, this comes from one of the clients that participated in interview. And I won't read it here, but really just highlights the amount of support that was given to the client in terms of finding an appropriate place to live. And the resource the person became in terms of helping the person get to a more stable situation. Next slide. And then the SPINS interventions also, in terms of employment support and how that was effective, or the types of activities that were done. One was just networking and identifying employment, where to start searching. You'll hear from our sites, several initiated and organized job fairs or connected clients to job fairs. And importantly, many of our staff really helped with the one-on-one with the job search and having that person there. Education and training was really critical. How to do the job interview, how to put many of our SPINS participants had not been in the workforce. And so how do you put a resume together? How do I get the skills that you need? As I mentioned, just fear of having the appropriate skills was a major barrier about returning to work. And that was something that the SPINS interventions were able to address and how to do interviews. The hands-on support with finding jobs, like learning how to fill out applications online, reminders and accompaniment to job fairs and appointments. So all this type of work within the employment sector was critical. But also the SPINS interventions were also helpful at a system level within Ryan White in terms of helping case managers and training and helping them understand what is the goals and the priorities for the client around moving towards employment or obtaining employment. So again, we heard this theme around employment, around motivation, and counseling was really critical. The encouragement to keep applying for jobs, to think about, you know, going into an entry-level job that could be a stepping stone onto another piece, another position, or providing mentorship and how to find the appropriate job or be in a position that works well for them and given their either health concerns or other concerns they may have. And then finally, just having someone there, having the employment navigators, coordinators who could respond to them when they had a question about employment, regular check-ins to keep them motivated and keeping them informed about the job process. So those are some of the critical components that how the SPINS interventions worked, implementation side to help clients find employment. And then here we just share a quote about a client who attended the job fair and how grateful they were and how they were successful because they were able to get job offers from there. And that was just a feeling of accomplishment for the client that we were able to achieve. Next slide. So at this stage, what I'd like to do, those are the overall findings from the multi-site side. And what I want to do right now is turn it over to two of our sites. First, we're going to hear from Eric Moore and one of his clients. Eric is a program manager for the HRSA Homes project, and he's a medical case manager at the Positive Impact Health Center in Atlanta, Georgia. And then we'll hear also from Travis Barnhart, who's the manager of quality and housing services at the Kansas City Health Department. So they're going to talk about their interventions and some of their impacts and lessons learned, and you'll hear from some of their clients. So Eric, I'll turn it over to you first.
All right. Hey, everyone. How is everyone? Let me know if there's any issues with my microphone. I've had a few over the last day or so. Well, greetings from Atlanta. Again, my name is Eric Moore from Positive Impact Health Centers. We do next slide. So this is our team for the Homes Intervention. The acronym is the Housing Opportunities, Medical and Employment Services. Over the course of the 3 years, we had 3 different case managers on the program. We had Andrea Flint, who is still with the team. She's an MSW. Charlotte Vick, who came onto our team in July. Charlotte just graduated with her BSW. And a lot of you probably remember Veronica Seabrooks. She moved back to Miami, but she was on the project for about 2 years with us as an MSW. And then the ever important Alfonso Mills, who was our study enrollment coordinator. I don't know how we got all the work done that he did over the time period that we had, but looking back on it, we probably should have had 1.5 Alfonsos. So I think I owe him a lunch or a drink or something for taking care of all that business over the course of the last 2 years. Go to next slide. So just a little bit about Positive Impact. We are in the metro Atlanta area. We have 3 locations, one in downtown Decatur, which is just outside of Atlanta, one in Duluth, which is just a little bit further outside to the north, and then Cobb County location that is further south. We serve 25 counties in the region. We have Ryan White programs, Part A, B, and C. We serve about 4,900 clients through that. When we took on this SPINS project, the home intervention, we were looking to serve clients that were out of care or experiencing homelessness and unemployment. We were looking to build capacity within the agency. I think this is one of the things I think I'm proudest of accomplishing is that when I first started at Positive Impact about 4 years ago, I came in as a medical case manager with experience in housing and employment. And looking at the way we handled medical case management, we asked the questions about housing and employment, but we really didn't offer any services. At the time, our HOPWA program was 2 people. And we did not offer any employment services. So now we're at the point where housing and employment is something that's asked by every case manager when they're doing new intakes, and it's something that we've kind of been able to build into the agency, offering those services. And I think we've come a long way over the course of 3 years, and it's a big resource for our clients to have access to now. And then also, on a broader picture, addressing the social determinants of health. Atlanta as a city and Georgia as a state, we are pretty high up there in new cases, pretty much every STI, STD case that you can imagine. And one of the biggest issues in the South is the way things are going in Atlanta. So that was one of the goals, was to address the social determinants of health. Do next slide. And these were some of our outcomes. This data was as of March of 2020. So you can see at enrollment, we had about 20% of our folks with some type of employment. As of March, that was up to 46%. And nobody was permanently housed, and we were able to bring that up to 63%. The engaged in care part, 44% in enrollment, and then 77%. And then the viral load suppression, again, went from 50% up to 65%. And I think, one of the key factors that was maybe unique to our agency, maybe not, but we really worked with some of the hardest to reach folks within our region. We were really looking to take people on that had all 3 of the factors that, Corliss mentioned in the beginning that were eligibility requirements, being out of care or lost to care, but then also being homeless and unemployed. So we were trying to kind of avoid the folks that were maybe, I shouldn't say avoid, but we really tried to seek out folks that were chronically homeless, or, folks that were sleeping in parks and stuff like that. So So our numbers, when I look at it, I do see that, our viral load suppression was 65%, but, our folks really started kind of, at the bottom of those percentages. So it's just nice to see that we were able to kind of work with the more difficult population and make some real changes. So if we go to the next slide. So today you're going to hear a little bit from one of our clients. His name is Mr. Ellington. I could talk to you all day about this guy. He was a character beyond belief. He had one of each. Like if you go down the list of all the things that Serena was talking about with barriers, he has some mental health, long time substance abuse issues, probably 30, 40 years. He's kind of distrustful of the whole medical system, which led to not only, poor HIV health outcomes, but also poor health outcomes in general. Definitely unstably housed. At the time that he came into the program, he was actually living in his drug dealer's garage, which was quite a conversation to have with him about how that was working out. He was just somebody who was extremely challenging, but it was every bit worth it as far as things go. Maybe later on when we have our Q&A, Andrea can kind of speak to some specifics, but he was just a very, very interesting guy, extremely smart. He knows what he was doing, but he just kind of needed a lot of hand-holding, kind of points in the right direction. As far as resources go that we went through with Mr. Ellington, we did a lot with him around budgeting, taking care of his money. He had a nice little pension. He had a great job. Most of his career, he had a great job. So he had a nice little pension, nice little retirement. It was just the fact that he was probably spending 95% of it on drugs, which led to the housing issues. Andrea did set up moving assistance for him as far as moving goes, just because he did obtain furniture through our furniture bank here in Atlanta. So he was in one apartment and ended up moving to another. We had a lot of Ubers all over town because he is older. I think he's 64 years old. So we didn't want to put too much stress on him with regards to constantly having to be on public transportation. Just overall, it was just in my opinion, a really great story because, like I said, when I did start at Positive Impact 4 years ago, he was somebody that was designated to be on my caseload, and I could not find this guy. I tried. Just could never hunt him down, could never catch up with him. And then one day, shortly after we had started the homes program, somebody mentioned to me, Mr. Ellington is in the clinic today, and I saw your name was attached to his profile on the medical records chart. I thought you should know. And I was like, I couldn't believe it because he was someone that had escaped me for probably the first two and a half years. I'm usually pretty good at doing outreach and finding folks. So the fact that he kind of popped up on that particular day, he was ready to go. He was seeking assistance because he did want to enter a program for sobriety, and it just everything just kind of came together. And it's a really great story. Everyone on our team knows him. You can't miss him whenever he's in the office. Everyone in the office knows him. So it's just, something that we're definitely proud of, this, particular individual. So I think we're going to hear his recording next, I think. Yeah, sorry.
Eric, this is the one that we have here. So could you actually tell us a little bit more about this client?
Sure. So this is Travis. He is actually gender nonconforming. Came into the study he'll give you a lot of background in the video, but he gave a lot of, he was going through a lot of housing instability, was couch surfing, was dealing with some survival sex, was having issues with getting employment because just could never really plant himself anywhere. Came into this, in terms of overall picture, he was able to go from being unstably housed, not having a job, was able to get a job, left that job, but then was able to get a job in the HIV field, which he'll explain a little bit about in the video as well. But really working with Andrew, he was able to gain that motivation that we've been talking about in terms of like pushing yourself from, okay, this is not just about where I'm at right now, it's about where I'm trying to go, and really utilizing the services that we have at PIHC to be able to push through the barriers, push through the boundaries, and really make some amazing headway in terms of becoming stably housed, in terms of finding a livable wage job, and then just kind of building self-sufficiency and not being so reliant on, the cars that we had or the MARTA, and really just owning himself and owning his life. And I'll let the video talk about the rest of his journey.
Hey everyone, what's up? My name is Travis Walker. I am 26 years old, Virgo Nation. I am originally born and raised in Chicago, Illinois. I recently, 2 years ago, moved here to Atlanta, Georgia, and I reside on the south side of Atlanta. And I am HIV positive. I was diagnosed in 2017 in Chicago, Illinois, and I'm here. So before working with Andrea, which is my caseworker at Positive Impact, I was going through some struggles. It's no shade at all. I was definitely going through some struggles. I originally moved down here to Atlanta, Georgia to pursue the acting, dancing, modeling. We were from literally like sleeping on people's couches. I had been in situations to where like people wanted to like, have sex with me just for me to lay my head down in their home, and even coming out as gay. It was a struggle just with my family even accepting me, and I kept on striving. I just kept on trying to look at the light that was at the end of the road, because what you see now was not what was being perceived. So when I actually met Andrea going into Positive Impact, I was broken. I literally laid everything out on the table for her, and I said, I need help. That's one thing that I definitely could say I appreciate about Miss Andrea, was the fact that she stood by my side every step of the way and made sure that you're gonna make it. Like, you're gonna make it. When she told me it's gonna get better, I literally thought that it was just a situation where it was just someone just doing their 9 to 5. But when she called me, emailing me, checking up on me, sending me to job fairs, even when I was homeless, she was able to put me in a hotel for 30 days. Like, those were the things that she has done for me. And off the strip of her doing that for me, that made me want to fight even harder, to be like, you know what, Travis, you're falling off the cliff, and there is someone that has reached out to help you up. It is up to you now to either grab that hand and pull yourself up, or you could definitely just say, like, you know what, I give up. So what did I do? I definitely made the decision to grab that hand and to pull myself up and to fight even harder, because I knew for a fact that my life meant more than what I was going through. If I had to reach out to another individual and let them know about this program, I would definitely tell them to do it, because this program has definitely changed my life, has definitely made me do a 360 in my life. And I thank you for just allowing these people to really just bless me tremendously, and not even just them doing their job, but going a step beyond and to check up on me and to making sure that I'm doing the things that I need to do to to get done so that I can continue to excel in life. And I just thank you. I really do. I truly do thank you so much. Like, y'all don't understand. Like, y'all be over here getting a little teary-eyed, but y'all don't understand that stuff like that truly lets me know that there are good people in this world that truly and genuinely care. Overall, I just truly do thank everyone a part of this program. And again, like I said, if I had to go in and tell another individual about this program, I would definitely say do this program and make sure that when you're doing this program, you got these people that's going to do the 50%. You need to make sure you're meet them halfway and making sure that you're going to continue, that you're going to fight and see the betterment of yourself, because what you're going through today does not determine your tomorrow. So always just make sure that you are continue fighting for the betterment of yourself. Not just because somebody else is just saying like, oh well, tomorrow's going to get better. Like, don't believe that tomorrow is definitely going to get better because of the fact that you're better and you're great. And I just thank you just for that, because it made me believe that for myself that I'm better and I'm great. Thank you.
Travis was a really good kid. He's, you know, an example of also like all the different resources we have and all the different supports, you know, because we did use Hopwa as far as lodging goes. And then when his lodging ran out and he still had not found a unit, we were able to pick him up from there so he didn't have to go back to the streets, or like Alfonso said, kind of end up back in a situation. And also, I think, you know, I don't want Alfonso to be sold short on this too. I think you helped him a little bit with the employment as well, kind of connecting him and getting him thinking about ideas about how to make changes and stuff like that. So, yeah, I think that's our story as far as our client goes. I think I'm going to hand it off now to Travis Barnhart, KC Life 360.
All right, thank you, Eric. So, yeah, we got to hear from another Travis there, and I found it interesting. At one point, he said it was a 360 in there, so it tied in well to us passing it on to KC Life 360. So, hello, I'm Travis Barnhart. I work for the City of Kansas City, Missouri Health Department. I'm the Quality and Housing Manager. Many of you are probably remembering that Jamie Shank was in that position, and she has moved on to being a consultant. So I am now in there in that position and still working with Jamie quite a bit. Before we move on to the next slide, I just want to mention we are one of those city health departments that were mentioned earlier. We are a Part A recipient, as well as we've had at least one other SPINS project in recent years. We also receive HOPWA and Continuum of Care HUD funding. So we have quite a few different programs that we worked across, and you'll hear that mentioned in the client story that I'll share here in a bit. So you want to move on to the next slide. So I didn't do an intro slide, sorry, to our team. We're actually presenting tomorrow in the late afternoon. I'll talk about our team more there. But on this slide, I did include just the overall intervention goals and the demographics, as you're all familiar with. For the overall intervention sites, we use these same intervention goals and demographics. Down there at the bottom, you can see our partners on this project. So as I mentioned already, City of Kansas City, Missouri Health Department. It's kind of the coordinating entity of the project. And then we also work with Catholic Charities of Kansas City and St. Joseph, as well as Restart. So the health department in this intervention served as the receiving entity of our service referrals. We worked quite a bit with our medical case management, HIV medical case management system, as well as our housing providers to get the word out about our program when we started KC Life 360. And really, one of the things that Serena mentioned early on in her presentation was about data integration. We had done a lot prior to this grant with integrating folks into our database that had traditionally been used solely by our HIV medical case managers, but we'd been working with our previous SPINS grant to get our housing folks in there. And that really set us up nicely where we could receive referrals at the health department through that data integration that was already in place. So once we had service referrals sent to us, we had a employment support specialist, Debbie Adams. You'll see her in the video coming up. Debbie would receive those service referrals, triage what was needed for the client. Was it housing? Was it employment? Was it both? And then really start a bit of case management with those folks to get them rolling with what they needed. If it was employment, quite a bit around employment, then there would also be a referral made to our partners at Catholic Charities who served as our workforce development folks. And they would work with our clients individually as well as in group settings on many of those different services that were mentioned earlier. Things like resume building, how to interview effectively, filling out applications online, et cetera, along those lines. They also had some funding to support if clients needed, let's say like a food handler's license or needed help getting a birth certificate, something along those lines in order to achieve employment. They could work with Catholic Charities on that. And then we worked quite a bit with our housing partner, Restart. We'd previously already had quite a bit of work prior to Casey Life 360 in place with Restart through our HOPWA program. And then more recently with Sir Brian White transitional housing funding through our Part A funds. So we worked with Restart quite a bit with what we call transitional housing. So clients that were in shelter at their main location, as well as a offsite apartment building that was also transitional housing. At that location, clients who were enrolled in Casey Life 360 would then receive support around not only their housing goals, but also their employment goals. They could receive assistance through the Casey Life 360 program with transitional housing needs. So let's say they did find an apartment that they wanted to move into. We could help them, Restart could help them with paying things like deposits and first month's rent, that sort of stuff. We worked together as a team. We actually met at least monthly during the project with our work group, our Casey Life 360 work group, so that we could case conference on clients and make sure that we were really providing the wraparound services that were needed. One other really great thing we were able to do with both of our partners was establish co-location of services. So frequently, Catholic Charities folks would come over to the health department and work in our suite there at the office so they can meet with both Debbie and then the workforce development folks from Catholic Charities. And then we also established a co-location agreement with Restart, particularly at that offsite apartment building, so that our employment specialists and Catholic Charities could go over to the building. Everyone could meet with the client in one space, and the client would not have to make multiple trips to meet with everyone on the project. We found that to be a really successful model in what we did. Last thing I would mention, of course, there was also the evaluation component of our grant with Casey Life 360, which was staffed by folks at the Kansas City Health Department. I actually, in my previous role, I served as the data manager in the project. So when I came on in May of 2019, I did a lot of the interviews and a lot of the chart audits. But we realized that we really needed to add another staff at one point. With BU, with Boston University, we also like to joke about the Mary Jo model. We brought on a nurse named Mary Jo Hoyt, who was able to really dig in quite a bit deeper with our, particularly into some of our partner agencies, electronic health records. We developed data sharing agreements with those partners, and she was able to really dig in and get the information that we were missing in a lot of our chart audits, particularly around things like mental health and substance use. Mary Jo, I also always praise her, and I'm always thankful for her that she took a lot of those interviews, or she took all the interviews and started doing those as well, and was very persistent in following up with our clients as we needed to do that. So we credit a lot of our successes with our chart audit data, our interview data to that model that we developed there. Okay, go on to the next slide, please. Okay, so I wanted to share with you, before we get to the client story, just some of our aggregate client outcomes. And this information comes from the final aggregate report that we just submitted earlier this month. So it goes from the very beginning of our first enrollment, May 29th of 2018, through the end of August of 2020. And one caveat I just want to throw out there, this is the highest level that clients achieved at some point during the intervention, not necessarily where they were at by the end of the intervention. We'll be looking at that more dynamic data set as time goes on, I'm sure. But we are happy to report that these outcomes for highest level achieved or maintained at least at some point during the intervention. I'm not going to go through all of these. At the bottom, you can see we had 84 clients in the study component, and then a total of 115 clients who were in the intervention and or in the study. So one of the most exciting things we get to report is that 76% of our clients achieved or maintained earned income, which includes either Social Security, social or disability, or some type of employment. And then in employment, you can see that we had 67% of our clients at some point during the intervention who achieved employment. And 53 of those folks were actually at some time full-time employed. Housing-wise, I did look at our overall client population, the total 115, and determined that we did have 90 of our clients, or 78% of our clients total, who achieved permanent housing, at least at some point. Further down, I just wanted to point out in the housing column, 11 were still at the homeless level when we looked at final aggregate data. But the way that homelessness was, one of the categories within homelessness was whether or not they were in transitional versus or a shelter type setting. So out of our 11 who were homeless, 10 of those were actually in the highest level they had achieved was transitional or shelter. So that off-site apartment building I mentioned earlier, many of our clients, that was the level that they were at during the time that they were in our KC Life 360 intervention. 75 of our clients, or 65% total, received some kind of housing assistance. And this is really where we looked at the full spectrum of housing services that we have had available through the Kansas City Health Department. You know, I mentioned earlier, we work with HUD Continuum of Care funding. We work with Ryan White Part A housing. We have HOPWA housing as well. But we are also really mindful that there are other housing assistance programs out there that we don't fund, we don't directly work with. And we were really always working with our clients to try to spread out their housing options and their assistance options as much as possible while they were in this program. A couple of healthcare related client outcomes. So for viral load suppression, at least at some point in the intervention, 94% of our clients were suppressed, virally suppressed, which is a really great outcome to be able to report. And then looking at engagement and care from the aggregate report, that was always looking at clients who had at least 12 months of enrollment. So by the end of August 2020, we had 80% of our clients who had hit that mark of being in the program for 12 months. And 89 or 94% of them were engaged in care at least at some point during the intervention. So very proud to report that outcome data to you. All right, next slide. Okay, so before we jump into the interview here with Courtney, I just wanted to give you a little bit of background about Courtney. So in our video, you'll see both Courtney Jones, the client, as well as Debbie Adams, who served as our employment support specialist in this program. Courtney came into our program shortly after her 21-year-old son had been murdered. And that was actually the event that led to her being homeless. So he was murdered right outside of her home. And because of her, the post-traumatic stress that she experienced from that event, she couldn't stay in her house anymore. It just didn't work for her to live there because of the memories. And so she moved into her truck and was living out of her truck. Debbie and I both met Courtney kind of at the same time. At the time that she came into the program, I was also working with our local continuum of care coordinated entry system and doing the homeless interviews for clients. And so Debbie brought Courtney over to me to do that interview. And Debbie and I can both tell you that when we first started meeting with Courtney, you could hardly get through 2 or 3 minutes of talking with her before she would break down and start crying because she was still experiencing so much trauma from her son being murdered. And it was really getting in the way of her being able to move forward in her life. Courtney was employed at the time, but it was a temporary job that she didn't really have much promise yet of that becoming a potential permanent full-time job. It was also located not in the core part of Kansas City. She actually had to travel about 30 miles from her home in order to get to that job. And, when she first started with us, she was living out of her truck. But at one point in the program, her truck broke down and she no longer had that as a resource. So she had to rely on coworkers to get her to that job that was quite a ways away. And I think she talks a little bit about that in the video as well. Courtney had achieved viral load suppression prior to coming into our program, and she actually maintained it throughout. But she started to really struggle with engagement and care due to her depression. You'll hear her talk about how that mental health piece really played a big component in her feeling like she was on the verge of dropping out of care and potentially becoming not virally suppressed anymore. We really wanted to highlight Courtney because she is one of the clients who really went through the full spectrum of the services that we provided with KC Life 360. So she went from being homeless to, then we moved her into our GAP lodging program. She was able to get into the transitional housing program, the offsite apartments at Restart. And then through the local HUD continuum of care, that interview that I did with her way back quite a while ago, she did finally come up as a client who was eligible for a voucher through that program. And she's still working on the process of finding an apartment now for that voucher. Trying to think if there was anything else. I guess we're ready to move on to the video. Thank you.
So in front of me, we have Courtney, and Courtney's going to give us some information about herself. Hi, Courtney.
Hi, my name's Courtney Jones. I'm 42. What else? I've been diagnosed with some things, and I've been in a program to help me get better.
Okay. Can you give us a little bit of your history of why you came into this particular program?
I came to the program because my son was murdered, and where he was murdered at, I was not comfortable, so it put me in a homeless situation. Is that right?
Yes.
And what else?
Were you working at the time?
Yeah, I've been working I worked my whole time. I worked my butt off. I was working, I was still in a homeless state, and it was hard to work and find shelter.
Okay. So before you came into KC Life 360, were there any challenges that you were enduring? I know you had employment, you were homeless, you were in the car. How was your medical care? How were you doing with your medical care?
Well, at the time, it was my mental state. I was always healthy, but my mental state had diminished because of the loss of my son. So I was a healthy person, but my mental state had played a big portion on me going homeless because I had became depressed and a lot of other things. So that's why I reached out to Miss Debbie. That's who I reached out to at the time because I didn't know I had never had the mental part of it to deal with. So, and that's when I reached out to Miss Debbie because I didn't know where to go.
Okay. And when we met, you were homeless in your car.
Yes, ma'am.
And so what was the process? I mean, once we connected, what steps, where did you go? What services were you provided?
Once I met Miss Debbie, once I actually allowed myself to receive the help, it made a big difference because my pride played a big part in it too. Because even though I was working, I wasn't getting anywhere. So and I didn't know the tools. It was a lot of community built. Wasn't nobody to talk to. So I found you all, and let's say I was homeless for 6 months. 5, 6 months. I stayed on the plaza. At a hotel for 6 months, and I still worked. And I was still homeless. And I had a mental breakdown, like I said, with the loss of my son and all that. So I never knew depression. I never knew about any of that. So I reached out to you all, and you all helped me so much with helping me find this resource where I'm living at transitional living right now. I'm not going to say that it was the whatever, but I put into it what I got into it. And I didn't go back into the depression and the mental health or the drug abuse or anything like that. So.
And you went from what we call gap lodging, which was the hotel lodging, into transitional. And what was the next step with your housing? You've been in transitional for about 5 or 6 months now.
Yep.
And so now, what's happening now?
Well, right now, I have a voucher to move into my own place, and I started my own business. Started a business in my son's name, CEH Hauling, to haul things. I saved my money. Well, the help with Miss Debbie and the program helped me save my money. The resources that they gave me helped me save my money, and I started my own business, the CEH Hauling. And I had to speak out and say that the help that I needed, because a lot of people are scared to say the help that they need to get the resources.
Okay. I have one last question for you. If you could tell another person that's in a similar situation that you were in with homelessness and kind of the mental illness piece, the depression, what would you tell them about this program? What would you say could help them?
I would tell people to open your mouth. Tell them what you need and the services you need to get you somewhere, because if y'all don't know, y'all can't help us. Or what you want to even do, and be consistent with it. Don't just get comfortable with like, hey, I'm here and not do anything about it. Like, utilize every source that they can give you for what you have to do to make yourself successful.
Yes, but you worked through it, you hung in there, and you did exactly what you just said. You would say what you needed. And that's, well, I appreciate you taking the time today to talk with us, because you can inspire so many people just with your desire to get better, to work through it. Yeah, it was tough. It was tough. And you worked through it, and you're kind of on the other side now. There's still some things going on, but I appreciate you
No, I appreciate it. People got to put their pride aside and ask for the help that they really need, and don't abuse it. Or in a sense, does that make any sense? Because
Yes.
you can abuse it and get like in yourself. But I stay prayed and focused, and with the help of, I call Miss Debbie my angel, and the whole program have been like little wings that I received for myself.
So thank you again. I know Courtney's not on here, but thank you so much to her and also to Debbie for that interview. That was actually the second take of our interview. We had a little bit of technical difficulties the first time around, but we were able to do it again. So yes, that mention of angels a couple times and the programs being like wings to our clients, I think we're going to hear that resonate throughout our time talking about this program. And I forgot who I'm passing it back on to, but I'll pass it back over to BU, to Serena. Thank you.
Thanks, Travis. And thanks, Travis and Eric, for and your teams. Those were just amazing stories. And you know, Eric, sorry about not having that other video, but your description and then the video, Travis's message and then Courtney's message really shows the diversity that you all were able to reach for the population who really needed this type of service and program. And so thanks to Courtney and Travis too for taking time to share that experience and their advice for us. So I just, I know we're getting close to the top of the hour or the bottom of this presentation, but I just want to share a few lessons learned, and then if folks can stay on, we can take a few questions. We do have plans for a break. It's a little bit longer, but if people want to stay and for a few minutes and ask questions, that would be great. So just a few points that we wanted to highlight in terms of lessons learned from this last 3 years that might be able to be shared with other Ryan White, HUD, HOPWA, DOL partners, community, the public health, HIV community. I want to just start off by saying, you know, these sites really worked in, we keep hearing this word, unprecedented times. This was a shorter life, our project cycle was shorter, 3 years, and then we had COVID hit right towards, not middle, but near the end of third year, where we still had lots of time for implementation, at least another half year. And so it really affected us. And to see housing and employment, one message I think we want to emphasize is housing employment stability. Achieving it is not a linear process. And we do need longer project cycle, especially when unexpected events happen, and to help people get to that stable housing and employment. Tom presented earlier, we had, you know, this was intense work that the sites were doing. On average, interventionists had about 32 clients with multiple needs, not just housing and employment, but also other comorbidities like mental health and substance use. And we got, just even in 6 months, and some of the outcomes Travis and Eric showed you, we're able to achieve or get people to at least be stably housed and virally suppressed. So just thinking about what it takes to really improve housing and stability, longer time cycles. Second, also critical that you may have heard through these presentations, that the need for a champion and leadership, and having this coordinator who can, particularly at a system level. We heard from Courtney, I think we heard from Travis, of like not where to go when you need these type of services. So having somebody who has that, you know, 5,000 viewpoint, who can really be championing for clients to make sure they get the housing, the employment, and the healthcare. I mean, kudos to HRSA for recognizing these social determinants and putting interventions in place that really are starting to address not just housing, but employment, because as Dr. Cheever said, they're linked. And having someone who can push that through, building those partnerships, making sure their clients can get through the guidelines and regulations is really critical. Third is, again, just to emphasize having that dedicated staff. People like Andrea, Debbie, Eric, Travis, all the intervention staff who were really there for coaching and empowerment of the clients. As you heard Debbie say to Courtney that that she did it. She did it, Courtney did it. She kept being persistent and asking the questions, and the fact that Debbie was there to answer it for her makes a big difference to foster that independence. Another key point we've heard from sites as well is this role of emergency housing support, and that being able to use the Ryan White SPINS dollars to provide that cushion when needed for sites and to move them along that process, as we saw with Courtney particularly, but also I know in Atlanta that Eric and his team were able to get clients connected in. Also our sites and many sites were able to do that in this initiative, and you'll hear more about that in the next coming days from our other partners. In terms of employment, the role of private landlords and business owners was really critical, and mainly in places where the sites reached out to DOL partners and agencies and created some of those partnerships, but the system can be challenging, particularly for some clients, and particularly those who were coming from a background of chronic homelessness or substance use, mental health, and the readiness to go into a DOL system might not be there yet. So looking at private landlords for housing, that's on the housing side, but on business side for employment was really critical in finding jobs for folks. And then finally, I think the other piece that was brought out, and particularly on the employment side, was that promotion of entrepreneurial spirit. And we heard that from Courtney, where she was able to use some of her resources to start her own business. And we'll hear from other sites who worked with clients to do that as well. Thank you, everyone. What I want to do now, if it's okay, I know we had scheduled a 30-minute break, but if we could just, Travis, Eric, if we can stay on, and if people wanna, we'll open up the lines right now and check in the chat if there's any questions that people have for us.
Yes. Hey, everybody. So Serena, Eric, and Travis, absolutely amazing. I thoroughly enjoyed this. I have a quick question in regards to the data that was being presented. I know it's a lot of early findings, but for employment, you mentioned that health was one of the top concerns for people living with HIV going back into the workplace. Was there like a top barrier in terms of housing issues that people were experiencing that could be talked about at all? Or I might have just missed that in the presentation.
Oh, that's a great question. In terms of housing barriers, we didn't have the short answer is we don't have a housing barrier per se on the quantitative survey, Alfonso, but I do know, and I don't know if Lucy's on, I know we asked some questions about, utility assistance and challenges with safety and the quality of the housing. Honestly, I haven't looked at that, but I could during break and get back to you on that. But we did collect a lot of that information. So we'll have to look at whether it was a satisfaction, quality type, or if it's due to other sort of payments or other types of barriers that they may have had. If you go, and Marina, can you, one way I also just want to think about it, if we go back to the qualitative data, if you can go back to that slide, just even the points that the clients met, I'm trying to come from client voice, Alfonso. If we look at that slide, in terms of clients talking about logistical support, and I think pieces around just the application for housing was really critical, or knowing where to go and look for a place and how to do that housing search. That came out in the interviews we did at the, through the multi-site study. But we'll look more in depth across all. And I don't know if any other sites want to comment. I know we'll hear on Thursday, there'll be many sites talking about their housing, I guess, 3 or 4 sites talking about their housing. So they might have some ideas as well.
Serena, it's Daniel.
Oh, Daniel, go ahead. Hi, thanks.
How you doing? Hello, everybody. Great work, everyone. To answer some of Alfonso, I think our experiences was those initial fees and stuff we had, and also criminal backgrounds, and trying to get them into housing and finding places that landlords accept them. So a lot of the bigger facilities for apartments and complexes, we started looking at private newspapers, local papers within communities, and also just searching different sites locally just to make the client feel more comfortable, because they were not too comfortable even going to DOL, going to other big places. They were more interested in local people just helping them and landlords and stuff. So we're looking for private stuff, but just additional fees, deposits, application fees, not having the initial money to get a place to live, which is, I think, normal across the work.
Thanks, Daniel. And Daniel, you, can you just tell folks, for those who are non-spins, that where you're from? And
Besides being at the river right now, I'm down in Texas. I'm in Texas, San Antonio, Bexar County Hospital District, and I'm the program coordinator for SPINS here.
Thanks, Daniel.
Yes.
I think Laverne also has her hand up.
Yes. In regards to the housing in New York City, our HRA program will pay for clients' apartments, but we ran into difficulty because when HIV first hit the system in New York City, clients were, trashing their apartments, so it had a bad reputation. And even though, they paid market rent, they still wouldn't take it. They would come up with, oh, we need your credit score, or you have to make 40 times, the rent. So we had to get legal involved to say, if you accept programs, you can't disqualify this client because of his income. But then they would use the credit score to disqualify him. People don't, oh no, you're going to trash my apartment. And I also think when we were talking about setup fees, they'll play move-in costs, but then that's it, I think the clients get $500 move-in costs, cash to go to a store. You can't even barely get a mattress at that. You don't have any pots and pans. So you really have to scramble and dig for your resources. Where can I go to get, sheets and stuff for the client's bed? And then, people don't want to be, you're moving out of SRO, then you're moving into an apartment and all you've got is the bed. There's no TV, no nothing, that just makes the client more depressed, and the cycle, okay, well, at least this is mine. It's hard to motivate people when they come, from the SROs into a situation which is, okay, this is my place, but it's really no different. I haven't advanced any further. So I think setting up programs, more programs that provided those initial things that clients need, and then I really, our HRA system, for clients that going back to work, that transitioning off, giving the clients a time to, okay, you've got a job now. I think 808 was the amount that you could make. Anything over that, then we passed a law in New York City, 30% of your income up until a certain amount. So that transition period is really good because we had clients, job making 36, and then it was like, oh, rent is all yours. Like, hey, I haven't had an apartment on my own for forever. So, you have to really stay and work with those clients to make sure they budget. And, just learn to take things one at a time, okay, so this month you can get this. Next month, put a little money aside, you can get that. So I think more resources for move-in and then also transitioning.
Thanks, Laverne. Any other questions?
Hi, this is Lanika Green Shofla with Avenue 360 and AIDS Foundation here in Houston, Texas. And my question is for Travis. First of all, I wanted to say congratulations on your numbers, especially the number of clients who were actually permanently housed. So my question to you is, what was the turnaround time for those clients being housed? And I'll ask that question because just a little background, here in Houston, we go through a coordinated access housing system where we assess clients prior to them being housed, and based on a specific number, it determines if the client is critically homeless and how they are actually placed in a housing program that's available for them. That seems to be a barrier for us because what we consider homeless, if a person doesn't have a stable place to stay, or they're living in a dangerous situation under the bridge, or from home to home or something like that, the definition of homeless is different for everyone. So that was a huge barrier for us with getting clients housed because they didn't meet that homeless criteria, even though they didn't have stable housing. And I just wanted to kind of know what was the turnaround time, because we've experienced clients being on the wait list years or, for a long period of time.
Yeah, that's a great question. It depends. I don't have like good data in front of me, for each of our clients in terms of like how long it took for them to get from an unstable housing situation to stable or permanent housing. One thing I would say is we really have worked hard over the last several years in our program to make sure we're leveraging as many different programs as we can. So like I mentioned earlier, like I've been really involved, or I had been really involved in our local HUD continuum of care coordinated entry system, which is where clients have to meet that HUD definition of homelessness, which doesn't necessarily match up with the definition of homelessness we have in Ryan White services and other programs, in order to even be interviewed to get on the list in the first place. That our local, it's called the by name list. Our local by name list has anywhere from 800 to 1,000 people plus on it at any given time. So like if we were only relying on that resource, for example, to get clients into permanent stable housing, it takes months, and some clients never even get referred to housing, even if they end up on that list. I know a lot of times when I did interviews with clients, if they weren't scoring really high on the vulnerabilities for that program, I would be very blunt and clear with them, like, you're probably not going to get housing through this program. But guess what? We did that interview. We're getting your name on that list so that we have at least one egg in that basket. Now let's go talk about all the other baskets that we can put some of your eggs in to pursue housing. One thing I would say, I know we've done a lot of work with is, since we are the HOPWA recipient or grantee, we work very closely with the subrecipient agencies who receive the HOPWA funding. And as they have openings in their housing programs, one thing that I have really worked with them on, Jamie and I both worked with them on, is yes, let's go through the process that we've already established with our medical case managers for you to get your referrals for that, but also let's cross-reference the clients that are being referred with the by name list, for example, so that we're getting the clients who have the highest vulnerabilities. We're helping move people, the most chronically homeless, the most vulnerable clients from homelessness into more stable housing as well. So I know I'm not really directly answering your question, but I think the biggest advice I would have is know all of your resources that you have, first of all, in HIV specific housing programs, but then also make sure that you're tapping into the larger homelessness service sorry, my tongue is tied. Homelessness service agency network out there, even beyond like what is your local coordinated entry continuum of care funding, what are some of the other resources out there? And sadly, of course, and I don't know of any community where you ask folks about, do you have enough homeless resources? Do you have enough housing for all your homeless people? No community is going to tell you, oh yeah, we definitely have enough housing. But at least getting a sense of all those different resources that are out there, that really helps the clients understand. The other thing I kind of wanted to add to like our conversation earlier is I feel like we have a lot of lessons that we can learn from what has been done in HIV medical care and medical case management. So I remember, I've been involved in HIV long enough that I remember when linkage to care still wasn't a thing, and how that was such a new idea of like, let's really do this intensive program with clients when they first are diagnosed with HIV to make sure that they really get engaged in care. I feel like we've learned so many lessons from that over the years that we're now finally picking that up in other areas. This whole SPINS project is a good example of how we're doing that now with housing and how we're doing that with employment. That people don't, our clients, we as people ourselves, just when we think about our own experiences, when we had to try to find housing for ourselves, like our first time or whatever, or try to find a job, you know, it doesn't just come naturally to us, like all these complicated systems. And it's really important to have somebody there who can be like a navigator to help walk you through the different processes to get you from being homeless into stable housing ultimately.
Well, thank you. You did answer the question and some of those tips you use, but of course, every state is different. And just thinking about how, you know, just like you did, we don't put all of our eggs in one basket. We do several different referrals, but when it comes down, they change differently beginning January, well, December of last year, that now everyone has to go through this coordinated access. So it's like you can still refer, but based on your critical homelessness number, if it doesn't meet that criteria, then you're either placed on the waiting list or you're not, and we have to provide another resource for you. But thank you so much, and congratulations for the numbers that you guys have accomplished over this time frame. And it was very good to see that you all were able to get 90% of your clients housed. So good job.
Thank you.
Thanks, Lanika and Travis. So I also just, Lanika, to your point in looking at your question about, is there some sort of threshold of activity people have to do or intensity of activity? Our goal is to look at this with our multi-site data as we go forward. So great question, and we'll put it on our agenda. From past initiatives, you know, we have not seen like a final number or time period that gets into that gets someone to housing stability. What we see is that in our last initiative, we saw it's circular, right? People will get to this point, particularly if they're coming from chronic homelessness, and then they may fall back again, even as long as out as 18 months. So having that support is really critical, and figuring out how to do that is critical piece. I also just want to call people's attention to other housing barriers. Clara Chen, our amazing data analyst, looked at some of the barriers associated with different housing satisfaction, quality, and having resources for basic needs. So again, you can see the vulnerability of our population that you all served. And finally, I think the other big piece around housing, at least as noting about this coordinated entry, you're not the only place, Lanika, but other place, and that's the reason for the partnerships of Ryan White and HUD trying to address this coordinated entry system and making sure our clients achieve. So thanks for bringing that to our attention. And I think sharing that across different cities, what's been effective in building those partnerships and helping clients get through that system is critical. Take a quick break and come back at 3 to talk about employment goals.